Really, over the next, hopefully 45 minutes, I'm going to walk you through some of the changes to our approach for how we might treat transform lymphomas. It's an infrequent occurrence, but something that can generate a lot of concern, both from patients and clinicians. But I recognize this is your opportunity to ask questions. And so I really want to make sure I spend enough time giving you ample opportunity to ask any question you'd like about this topic, and we'll hopefully get to it towards the end of the session. These are my disclosures. I'm going to start with a case, actually two cases, because transform lymphoma is unpredictable. And I'm going to highlight two real cases in my clinic that kind of speaks to the heterogeneity in terms of how transformation can occur. So I'm going to start with this first case. This is a 66-year-old male. This was actually about 5 years ago. He has no significant medical history, was otherwise healthy, really didn't take any medications at all. Was doing quite well till he noticed a left inguinal lymph node. So it's kind of right where the crease of your pants is in the groin area. It was easily palpable. It wasn't really changing. Initially thought it might be a hernia, but was not tender. It didn't seem to fluctuate at all. So after a brief period of observation, he sought attention of his primary care doctor, who realized it was a lymph node. You can see here, this is a PET scan. So this is the PET view or the scout view where it's, and you can see this little black round lymph node here in the left groin. The blackness indicates sugar uptake. So that clues us in that this is abnormal. So this again is in 2017. He undergoes a biopsy to figure out what this is. So the whole lymph node is excised. This scan was done prior to removal of the lymph node. And you can see the actual path report here. This is follicular lymphoma. So it's important to recognize transformation generally implies that patients have an indolent or low-grade lymphoma that precedes the diagnosis of a more aggressive lymphoma. And traditionally, we will call it transformed follicular lymphoma, or oftentimes the terminology we'll use is diffuse large B-cell lymphoma. But you can see here in 2017, the patient has follicular lymphoma. So step one, he has a preceding indolent lymphoma. Because this lymph node is excised, and you can see on the PET scan, the only other real uptake is in the brain, heart, kidneys. He does have another small mesenteric node, so he's technically stage 2. The kidneys are draining here, so you do catch a little bit of urine as it passes through the ureter and it exits through the bladder. So because he had more than one site, he was observed. If it had only been the groin, we might actually talk about radiation for stage 1 disease. He completes his staging workup with a bone marrow biopsy that doesn't show any signs of lymphoma. It's actually a healthy bone marrow. So again, stage 2, his LDH was normal. So most patients want us to be able to peer into our crystal ball and predict what's likely to happen over the next 5, 10, 15, or 20 years. And it's really challenging to do that, though we have some tools, and such tool is a Flippy score, which takes into account age, stage, LDH, hemoglobin, and number of lymph node sites. You can see this gentleman over 60, his only risk factor is age. So for all accounts, he should be facing very favorable 10-year overall survival. So once again, he's observed. This was 5 years ago. He does really well up until about a month ago when he comes in for a routine follow-up. His wife is accompanying him. She doesn't always join him on his visits. So that's sort of my first clue that something's going on. And she's concerned that he may not be totally forthcoming about what's been going on. So she's concerned that his energy level is dropped off pretty dramatically so in the past 1 to 2 months. He's not able to keep up with standard chores that he'd been doing. And he's no longer doing some of the social events he enjoyed as a result of fatigue. His labs are notable that his LDH, which had been normal all along, is now 2 times the upper limit of normal. So not just slightly elevated, but pretty substantially elevated. And so on imaging, you can see this PET scan. So again, I highlight this new area here. He has some other small lymph nodes below the diaphragm, but this one is quite large. And with the LDH being high and he has new B symptoms, a biopsy is pursued. You could potentially just conclude that this is progression of his follicular lymphoma, but some of the features that might clue you into transformation, again, are those B symptoms and the LDH being quite high. The other factor that I don't show here, the SUV, which is a measure of how much sugar uptake in this mass, was also quite high and higher than I would expect for follicular lymphoma being about 24. Now, there's not an absolute cutoff for when the LDH above a certain level, you can conclude that there's transformation, but that might clue us in to be a worrisome sign, and this patient, in my opinion, warrants biopsy. So that's the other important feature about transformed lymphoma. Sometimes we make a clinical judgment about our best estimate as to whether or not patients have transformed based off, again, B symptoms, LDH. Another lab that can clue us in is calcium if that's elevated. But generally, we like to pursue a biopsy to confirm that it is transformed disease, because the treatment's going to be vastly different for transformed lymphoma versus follicular lymphoma that's now progressing. So biopsy is pursued. This time we don't excise the whole lymph node. We just do a core needle biopsy, which again, for patients, y'all are well aware, sometimes that can be much less invasive. It can be done usually within a week at a center like ours. And sure enough, this is now diffuse large B-cell lymphoma. There are different subtypes of large cell lymphoma. Follicular lymphoma is a germinal center type B-cell lymphoma. And so generally the transformed cases that arise out of follicular lymphoma will also be a germinal center like phenotype. Why I highlight that, I'll mention in a couple slides a little bit later on in the deck. So now, what do we do for this patient? Again, so this is someone, to summarize, he had follicular lymphoma diagnosed in 2017. He was never treated for his follicular lymphoma because he had essentially low tumor burden, was otherwise asymptomatic. On routine follow-up, he has new B symptoms, LDH is high, SUV is high on PET, and he has a new mass. And so he has transformed disease. I highlight this because it's usually not something that is triggered by treatment or the type of treatment patients get. And I'll walk you through what our current understanding is to how does this actually occur. Here's a very different case. Again, this is an actual case of mine. So this is a 64-year-old female. She initially presented to her emergency room with flank pain and hematuria, so blood in her urine. Imaging was pursued and revealed she had a kidney stone that was causing obstruction to outflow of her kidney. But also she had some incidental findings, meaning they weren't looking for this. They were looking for the cause of her flank pain and hematuria, which they found, which was the kidney stone. But they also stumbled across some lymph nodes in the mesentery. Oftentimes they're deep down. We can't get our hands on it. So a patient nor a physician is able to feel those lymph nodes. So she undergoes a biopsy and is found to have follicular lymphoma. There are different grades. The other patient also had grade 3A follicular lymphoma. So sometimes in a setting like this, where you see half the lymph node has lower grade follicular lymphoma and one area has a higher grade, we sometimes ask ourselves, is that a sign that you have transformation occurring within that lymph node? And my pathologists tell me not always is that true, but again, something that may clue us into something changing within this lymph node. She also completes her staging, and I purposely pulled these patients that had similar baseline features. So again, both had grade 3A follicular lymphoma. Both were otherwise asymptomatic. Once her kidney stone resolved, her symptoms had stopped. Both are stage 2 because they have lymph nodes on one side of the diaphragm. Both have a Flippy score of 1 just due to age. So she actually undergoes treatment for her disease, given that some of these lymph nodes were in an area where there was some concern for her developing lower extremity edema and being at risk for a deep vein thrombosis. So she completes 6 cycles of bendamustine and rituximab, which is some of the most common approaches patients get in frontline follicular lymphoma. And though her initial PET actually improved, so she had an interim PET, by the end of her 6 treatments, she had progressive lymphoma, and a biopsy was pursued. And the reason why the biopsy was pursued, because that's unusual. I would say most patients who get frontline bendamustine rituximab for follicular lymphoma will have a response, and that usually lasts for about 5 to 7 years on average. So to have someone who's refractory to bendamustine and rituximab is quite unusual. So biopsy is pursued and still reveals follicular lymphoma. There's no other lymphoma present. At this point, she proceeds with rituximab and lenalidomide. She's a college professor. She was hoping to pursue a therapy that was not going to have a significant impact on quality of life or require her to miss much work. And so for those of you who have follicular lymphoma, know there's lots of different approaches, including our CHOP, rituximab plus lenalidomide, plus a number of clinical trial options in this setting, given she's a POD 24 patient, someone who experiences progression within 24 months of their frontline chemoimmunotherapy. So we chose rituximab and lenalidomide, given it's something that can be done in an outpatient setting, and the side effect profile is generally a little bit more favorable than R-CHOP, for instance. And she initially, again, responds initially, but then within 6 months, she has progressive lymphoma. And you can see this scan now. So not just lymph nodes in that groin and pelvic region, it's now extending up throughout the abdomen, both sides of the pelvis. So at this point, a biopsy is pursued. So she's had 2 prior treatments for her follicular lymphoma, not responding to therapy like we would anticipate. She has a biopsy that also reveals diffuse large B-cell lymphoma, similar GCB phenotype. MYC is negative. I'll tell you what that means in a second, why that's important. So she actually proceeds with R-CHOP, which is the most standard treatment for large cell lymphoma, independent of, again, the follicular component, and has a complete response, meaning her lymphoma completely resolved. So we're celebrating. We finally got her into a complete response. She's eager to go back to working full time. And unfortunately, 6 months later, the lymphoma recurs. So again, 2 cases that started off very similarly, had very different outcomes. And so now let me walk you through how we might approach this clinically. So the first thing to recognize, because patients with follicular lymphoma, or again, having a preceding indolent lymphoma, they're not all transformed from follicular. It's just follicular is our most common indolent lymphoma. So most transformed cases do arise out of follicular lymphoma, but they can arise out of marginal zone lymphoma. And the latter half of this talk, I'll talk about Richter's transformation, which is a situation that occurs in patients who have preceding CLL. So the first thing to recognize is that for patients who experience a progression event within 24 months, which is our second case, we know those survival outcomes are quite poor. But the challenge with this observation is that many of those patients did not have biopsies. So the important thing to remember is for the majority of patients with follicular lymphoma, about 80% are going to have a normal life expectancy despite having follicular lymphoma. But the patients who have much less favorable outcomes are generally those that progress within the first 24 months. When we look in the era of PET, where most patients are getting PET scans to determine their response to particularly frontline chemoimmunotherapy, what we found is that there's a large portion of patients that are actually transforming, and we're just not getting biopsies to prove that. So what leads to transformation? Well, the current school of thought is that there's 2 different clonal evolutions that occur. So if you think about how do patients get follicular lymphoma in the first place, most of the time patients have normal bone marrow or precursor B cells. They acquire this translocation 1418, which leads to overexpression of BCL2, which is a protein in a family of proteins that tell cells when it's time to normally die off and get replaced by new cells. Almost all of the cells in our body have a normal life expectancy, and they're replaced by younger, newer cells. As we age, that process is not as efficient as it is when we're younger. But when you have overexpression of BCL2, cells don't die like they should. So follicular lymphoma cells tend to live longer, and then they acquire additional mutations or genetic aberrations, mostly because they tend to reside in that germinal center of a lymph node where there's somatic hypermutation occurring frequently. So when you are exposed to an infection or a vaccine, you mutate your B cells until you pick the winner that binds most precisely to that antigen that you're trying to generate antibodies to. And so by living longer and living in this environment where mutations are frequently occurring, you tend to have more mutations that occur. And so again, we think one way that patients develop transformation is that these follicular lymphoma cells that are sitting in this genotoxic environment continue to have mutations that are acquired independent of treatment. And then they acquire these more aggressive mutations that leads to transformation. So that's a linear evolution. Another school of thought is that these sort of stem-like or stem cell-like cancer cells at any point, just by sheer bad luck, can have this malignant clone that pops up that leads to the transformation. So you still have follicular lymphoma present and occurring, and you just have this one cell that pops off that's a transformation case, and it becomes more aggressive in nature. So if I had to put the two cases into context that I just showed you, the first case where the patient had follicular lymphoma for about 5 years, and then eventually showed up with transformation, and essentially the only lymph node that we biopsied was all diffuse large B-cell lymphoma, probably falls into this linear evolution camp. Whereas our second patient, because she wasn't responding traditionally to standard treatment, was probably in the second camp where she had divergent evolution. We were biopsying lymph nodes and showing follicular lymphoma, but we were just missing this transformed malignant clone of cells that became the more dominant clone over time, since it wasn't responding to treatment aimed at follicular lymphoma. And here's another description of this. These are 4 different cases of patients that had follicular lymphoma where they were pursuing biopsies at various time points. And again, you can see sort of this linear progression here where they just tend to acquire more mutations over time, and then eventually they transform, where you have some of these divergent clones that emerge, where again, you have the follicular lymphoma cells out here, but they have arising from the same sort of stem cell-like feature or progenitor cell, the transformation occurs. They have similar mutations, though, again, at different time points in the disease history. Are there ways that we might be able to tell patients that this is occurring, given the limitations of our current biopsies, where we generally will sample the most accessible lymph node, or for utilizing PET, the lymph node that has the highest SUV, and it's not practice or common practice to go through and sample every single lymph node, and I don't think patients would sign up for that either. Well, one such technology that's emerging, it's not currently standard of care, meaning you'd have to get access to it on a clinical trial, but is to look at circulating tumor DNA. Essentially, lymphoma cells are actually dying off every day, though they're much better at surviving than normal cells. And whenever they die off, they release their intracellular contents, including the DNA, and that's out in the peripheral blood. And we can look for the most common mutations associated with diffuse large B-cell lymphoma just in patients' peripheral blood. And then by detecting those mutations, you could suggest that, patients likely have diffuse large B-cell lymphoma somewhere in their body. And here is a prime example of a patient where they had started on R-CHOP, and you can see the circulating tumor DNA goes quite low, though it doesn't fully get down completely to negative state. The PET clears up. Unfortunately, the circulating tumor DNA starts to rise. Eventually, they see it on the scan again. And so this might be a complementary tool and potentially may even replace imaging at some point. But why this can be very helpful is you could actually look for, again, those sort of divergent clones that emerge and identify mutations that are more common in large cell lymphoma among patients with follicular lymphoma, and that may clue us in that transformation is occurring. Again, not quite yet ready for prime time, but something that I'm hopeful will be available to us in the next few years. As I mentioned, mostly what we're relying on right now are clinical tools to tell us that patients have transformed. So those B symptoms that we always ask about, and I've had patients frequently tell me, why do you ask for that all the time? I never have had these symptoms. And I tell them, well, that's reassuring, because if you have these symptoms, particularly the drenching night sweats, the fever and the absence of infection, weight loss, which is 10% of your body weight within 6 months, that's going to make me really nervous about transformed disease. And that may push me to biopsy. Whereas if you come in and you have a small lymph node and you don't have any of these worrisome symptoms, I may not pursue a biopsy every time we see changes on scan. How do we risk stratify patients? So I mentioned the Flippy score, which is commonly utilized among patients with follicular lymphoma. Once patients have aggressive disease, then we have an IPI scoring system that's been modified over the past few years, including the revised IPI that has been studied in the rituximab era, and then the NCCN IPI, which tries to more precisely risk stratify patients. And again, you'll see some of those classic features jump out, such as LDH. Also extranodal sites, so having lymphoma outside of the lymph nodes, such as bone marrow, liver, lungs, the CNS or central nervous system. Having any of these features gives you a more a cumulative score, and the higher the score, the less favorable the survival. Though I would say most of this doesn't help us in an individual. It mostly helps us compare patients across studies, and again, try and be a little bit better at predicting the future. So I think the other important aspect to consider when we're talking about transform lymphoma is patients will have the transformation occur at various time points within their disease course. I gave you two cases that were good illustrations of how different this could happen. You can have patients that live 10, 15 years with indolent lymphoma and have transformed. I've also had patients, as I illustrated with the second case, that within a year has evidence of transformed lymphoma. So how might we approach that? For patients that have not had chemoimmunotherapy, then we generally approach it just like you would any diffuse large B-cell lymphoma. I'm going to come back to this. High-grade B-cell lymphoma are patients with diffuse large B-cell lymphoma, but they have MYC gene rearrangement and BCL2 and or BCL6. And so patients with follicular lymphoma, that translocation 1418 is the BCL2 rearrangement that leads to BCL2 overproduction, which we highlighted. So all patients with follicular lymphoma, generally speaking, will have one of the double hit features. And so we're always on the lookout for MYC, because that may put patients into a more aggressive disease course, and we may need to intensify our chemoimmunotherapy. How do we approach someone who had R-CHOP for their follicular lymphoma 3 to 4 years ago and are now transforming? The backbone in the R-CHOP regimen is doxorubicin, an anthracycline that's oftentimes referred to as the red devil. We have a lifetime limit to how much we can safely expose patients to anthracyclines due to concerns about causing weakening of the heart muscle. So generally for patients who've already had anthracycline, we'll move forward with salvage chemotherapy and an auto transplant and forego the R-CHOP given it's already been given. That's why it's hard to really have one size that fits all for transform lymphoma, because we have to account for what their prior treatment was. And it makes enrollment on clinical trials really challenging, because how do we account for prior therapy if it was aimed at a different disease? And oftentimes clinical trials will exclude patients who've had prior therapy or other cancers when we're talking about a frontline treatment for diffuse large B-cell lymphoma, for instance. But fortunately for patients, because outcomes have been viewed to be quite poor, we're doing a much better job in that second or third line space, particularly with some of our novel therapies, which I'll walk you through. As I mentioned, we generally viewed transformation as a worrisome finding, something that outcomes have been quite poor historically, though again, part of the challenge is that many patients were getting R-CHOP for follicular lymphoma 10 to 15 years ago, prior to the introduction of bendamustine rituximab into the treatment landscape. And so you can see for patients who've never had R-CHOP, but get R-CHOP at the time of transformation, they do quite well. And this survival curve, so this is the percentage of patients alive over time, looks very similar to what you would expect for patients who have de novo diffuse large B-cell lymphoma and never had a preceding indolent lymphoma or treatment for indolent lymphoma. Contrast that to this other curve. So these are patients who've had R-CHOP prior to their transformation of it, and their outcomes historically have been quite poor. Fortunately, we have a number of good therapies now that may address this particular worrisome finding. And in the past, we used to quote patients, and I hate actually being put on the spot to give people numbers, because I always tell folks, if you ask me how long I'm going to live, I can guarantee that I will be wrong. But where I do think it's helpful is people need to know what their chances are with standard treatment so that they can potentially pursue clinical trials or make those hard life decisions whenever they're of sound mind and feeling well enough to do it. So historically, we've told people the average life expectancy for patients who have transformation is about 4 to 5 years. I think this is improving given the newer therapies that are entering into the treatment landscape after this has been published. But again, that's a very different outlook than patients who have follicular lymphoma, who we tell them they have at least an 18 plus year life expectancy and should be anticipating a normal life expectancy. So R-CHOP's the standard approach for patients with diffuse large B-cell lymphoma. Is that true for transformation as well? Well, I just showed you survival curves that for patients who've never had R-CHOP performs particularly well. But what do we do for those patients who've already had it or that's not an option? Well, there's two ways to think about this. One, so again, here's another survival curve, percentage of patients alive over time. These patients out in this curve, part of the curve, are doing really well. So that tells me we're curing about 75% of patients with diffuse large B-cell lymphoma with R-CHOP. So we don't want to tinker too much for these patients because they're going to do well. Maybe we should just focus on reducing the toxicity. The bigger challenge is for these folks, those patients who progress quickly within the first year. These are the folks that need something other than R-CHOP. And can we do a better job of identifying who they are? One way to try and do that is to determine the molecular subtype of the diffuse large B-cell lymphoma, because just like follicular lymphoma in transformation or transformed patients can be very heterogeneous, diffuse large B-cell lymphoma is a catch-all phrase that likely refers to about 7 or 8 different types of diffuse large B-cell lymphoma. The features that worry us the most are those double or triple hit features, as I mentioned, where you have to have a MYC gene rearrangement and either a BCL2 or BCL6. Triple hit just means you have all 3. By definition, most patients with follicular lymphoma have the BCL2. And so we're always on the lookout for the MYC rearrangement because that would suggest a much more worrisome outcome. And again, they generally more commonly occur in this germinal center subtype of large cell lymphoma. The activated B-cell subtype we tend to see more commonly in patients who've transformed from marginal zone lymphoma, for instance, and maybe even CLL. And so in this camp, we're also looking for double expression of MYC and BCL2. And again, those subgroupings may tell us that we might need to be more aggressive than your traditional R-CHOP. It's hard to know right now what's the preferred approach for double hit patients or high-grade B-cell lymphoma patients. In our center, we looked at more intensive regimens such as EPOCH and compared that to regimens such as CHOP or hyper-CVAD. And similarly, the NCR, the National Cancer Institute, also showed more favorable outcomes with EPOCH. The challenge is that this was retrospective, so we looked backwards over time to see how we had done. So it wasn't a randomized comparison. And so there was a head-to-head comparison of dose-adjusted EPOCH-R versus R-CHOP, and unfortunately, it was a negative study. So though you can see maybe a little bit better outcome in this blue curve with the dose-adjusted EPOCH, and the red curve, the R-CHOP, statistically speaking, it was not a significant difference, and the toxicity was higher with dose-adjusted EPOCH-R. So as of right now, I would say we still will personalize therapy for those high-grade or double hit features, and maybe there's still some patients where EPOCH makes sense, but probably the best strategy right now is to try and pursue a clinical trial. Another recent development is the POLARIX study, which looked at polatuzumab, which is an antibody drug conjugate. So it's more targeted chemo delivery to cells that have CD79B on the surface, which all large cell lymphomas do. And so replacing vincristine, which is one of the older drugs in the backbone, the O and CHOP, with polatuzumab. That was the experiment, and it was compared head-to-head to R-CHOP. And this was for patients that were 18 to 80 who had an IPI score of 2 or higher. As I mentioned, that's how we risk stratify patients. And you can see here that the patients who had polatuzumab plus rituximab, cyclophosphamide, doxorubicin, and prednisone actually had a significant improvement in their progression-free survival. So that means how long they remained in remission without having a progression or death event. So again, not a dramatic difference here, but a statistically significant improvement, suggesting that there was a reduction, about 27% chance of progression or death if patients got polatuzumab instead of vincristine. So this is one approach I would consider for patients who are particularly double expressors, who are older, who have an IPI of 3 or higher. And that's because the toxicity really wasn't much different at all. About the only thing that maybe suggested that the pola added something was febrile neutropenia, though again, the overall survival was no different in this population. So that's a new therapy that could be considered for transformed cases who've not had an anthracycline. What do we do for older patients? What do we do for someone who's had follicular lymphoma, for instance, for 15 years, and they were diagnosed in their 60s, and now they're being diagnosed with transformed disease? So for patients where CHOP is not an option, either due to having had a prior anthracycline or they've got cardiac risk factors where the anthracycline is not attractive, then you can exchange the doxorubicin with etoposide or gemcitabine. For older patients who have inadequate cardiac function, you could attenuate the doses, so give a milder course of CHOP with, again, lower doses. So these are options. There are a number of trials actually right now that are being explored for older patients that are generally taking into consideration the newer therapies, which I'll highlight next in this talk. So we covered our frontline approach. So what do we do for someone who's already had an anthracycline or they've had our CHOP and their lymphomas come back? Well, things are changing pretty dramatically right now for the second and third line setting. And that's because there have been a number of clinical trials that have read out that have really impacted how we approach this disease. Traditionally, what we've done is gone straight to salvage chemotherapy. And for patients who have a complete response on imaging, they underwent autologous stem cell transplant after high-dose chemotherapy. What's changed is if patients progress within a year of frontline therapy, CAR T-cell therapy, specifically axi-cell and lyso-cell, are now the preferred option for those patients who relapse early. For patients who are not candidates for intensive therapy, then we've got other options right now that are also recent developments, including tafasitamab and lenalidomide. And then patients, unfortunately, we still have patients that may not respond to these therapies. So in that third line or later setting, we have a number of options, again, that have emerged in the last few years. So let me walk you through what we might consider. So the first thing, well, what is cellular or targeted therapies? There are a number of different options. CAR T is where we take T cells out of patients' bodies. So that generally means they have to undergo leukapheresis. So they sit in a chair while their blood is filtered for about 4 hours. We technically remove T cells. So T cells are a type of white blood cell that's actually equipped to eradicate things like cancer and infection. But for our patients, those T cells are failing to see the lymphoma cells, so we need to modify them. So generally using a viral vector, because viruses don't actually carry their own machinery to replicate their DNA. So they have to insert themselves into a host cell to replicate their DNA. So we use those properties of viruses to introduce this new genetic material into patients' own T cells. And so now these T cells have sort of a homing device that targets CD19, which is a protein on the surface of all mature B cells. And all transformed cases, generally speaking, are a mature B cell. They've got CD19 present on the surface. The CAR means it's a chimeric antigen receptor. So again, it has some foreign protein that was not of that human that they were born with, and it targets CD19, but it's also been modified so that when it binds its target on the surface, it's sort of supercharged. So it will automatically get the signal that this should not be here. Let's get rid of it, and it will kill that cell. And they're actually serial killers, so they can actually go around and kill more than one cell that has that surface marker. There are 3 that are currently FDA approved: axi-cell, tisa-cell, and lyso-cell. There are other ways that we can target malignant B cells. So antibody drug conjugates, I mentioned polatuzumab is a great example. I'll also talk about loncastuximab. So these are antibodies. So similar to their antibody on the surface of T cells, they are not connected to an immune cell. For antibody drug conjugates, there's chemo linked to it. So it's targeted delivery of chemo. For unmodified antibodies, such as rituximab and tafasitamab, these are antibodies where the immune system sees the tail end, just like it's any antibody attached to any infection. And those T cells, NK cells primarily, can see it and eradicate the cell it's attached to. And then bispecifics, where you have the antibody head that engages the tumor, and you've got an antibody that actually engages the patient's own endogenous T cells. So these cells have not been removed from the body. They've not been modified in any way. But again, we help them see the tumor cell by having a bispecific antibody. One head binds the tumor, one head binds the T cell. And so I'm going to walk you through, because all of these options are now approved for patients with not approved, but have been studied. The bispecifics we're anticipating will be maybe later this year. So here is the schema of CAR T-cell therapy. The biggest challenge right now, in my opinion, is you have to be referred to a center to undergo leukapheresis, because we can't go ahead and collect the cells and just put them in a freezer. The collection of the cells is tied to the manufacturing, and for us to proceed with that process, you've got to get insurance approval, and that has to be done at a center that is certified to collect the cells, ship them, and then administer the cells. Axi-cell, T-cell, and lysocell, they're all the same in terms of the extracellular receptor, the CAR component that binds CD19. They do vary in their intracellular co-stimulatory molecules. Again, that's the signal that automatically tells the cell we need to get rid of this target. Axi-cell has a CD28 co-stim, whereas T-cell and lysocell are 4-1BBs. Where it matters to patients is the T-cell and lysocell are really mild in terms of side effects in the first 2 weeks, very low rates of cytokine release syndrome and neurotoxicity, whereas Axi-cell is the CD28 primes it to give more rapid expansion and recruitment of other inflammatory cells. So cytokine release syndrome is really common, as is neurotoxicity. We've been debating whether or not those features are dramatically important to distinguish between these CARs. Probably what matters the most is safety in the first 2 weeks. And so for our older or frailer patients, we might pursue this option. All patients actually have to undergo chemotherapy before we infuse these cells back in, because they look different from what was removed from the body. And so we have to, again, acknowledge that the chemotherapy does precede the cell infusion. Fortunately for patients, prior to the approval of CAR T, most patients were anticipating an average survival of about 6 months if they had failed 2 lines of chemotherapy, some of whom had had an auto transplant. But across all 3 of these single-arm studies, you can see that at least 40% of patients are cured with CAR T-cell therapy. And that's, in my opinion, the most impactful therapy we have really had approved in the last 10 to 15 years, probably since rituximab, because there really wasn't anything else beyond a stem cell transplant that could actually cure patients. And there were a few patients that we could actually even get to transplant. So it is a one-time treatment that can cure patients in the relapsed refractory setting. So because it looks so good there, the next question is, well, shouldn't we move it into second line? And that was done in 2 trials. And so now we do have 2 CARs that are approved for patients who've had 1 line of therapy but progressed within 12 months. Now, where it gets really tricky for our transformed patients is, can you count the therapy that was administered for the indolent lymphoma? In my experience, you can if they've had R-CHOP, which is a standard treatment for large cell lymphoma. If they haven't, then we still have to do large cell lymphoma AIM therapy, such as R-CHOP, which is appropriate given that some of patients may be cured with R-CHOP therapy. Okay, moving beyond CAR T, we have other options. As I mentioned, tafasitamab is a CD19 antibody. It's not linked to a T cell, it's not linked to chemo, but it's been engineered to engage NK cells better than drugs like rituximab. And so when we pair it with lenalidomide, which is an oral immune modulator, so that means it stimulates T cells and NK cells, it works really well together. And so the L-MIND study was done in patients who'd had at least 1 prior line of therapy, but not more than 3. And so most were in that second line space. And you can see here, those patients who had a complete response, the vast majority stayed in response and had not had a progression event, and survival was phenomenal. So over 35 months survival. So the goal with tafalin, in my opinion, is to try and get to a complete response. And if you do, those outcomes can be very favorable. And this is a non-chemo option. So you could consider this in second line for patients who are deemed poor candidates for CAR. So they may not be able to tolerate the cytokine release syndrome or neurotoxicity, or maybe they just don't have it near them because you have to be within 2 hours of a treating center. So this might be an alternative option. Another agent that's been studied for patients in that relapse refractory setting is loncastuximab, which is an antibody drug conjugate targeting CD19. This is a chemo-linked antibody. But what's nice about it, it's an IV therapy. It's a single infusion. So for patients who don't have good oral coverage from an insurance standpoint for lenalidomide, that can be challenging. Loncastuximab, it's all given IV. So we have this sort of loading dose that happens in the first 2 treatments. So it's given every 3 weeks, and then we get more to sort of a steady state, and it's generally given for about a year. So it's also an effective strategy. You can see here about 20% of the patients in these 145 single-arm phase 2 study that led to FDA approval had transformed disease, pretty heavily pretreated. They'd had a median of 3 prior lines of therapy. Over half were refractory to their last treatment. And you can see that there are patients who've had prior allo, auto stem cell transplant, or even both included on this trial. Now, again, it's hard to compare across these studies. I don't want you to look at these numbers and say, well, that doesn't look as good as CAR-T or Tafalin, but this was a single agent studied in a pretty heavily pretreated patient population. It's a 1 year of therapy, and the response rates were quite good, including in those high-grade B-cell lymphoma patients. So again, about half of patients had a response, and the median duration response was about 11 months. In terms of side effects with Lonca, it's generally tolerated really well, but there's 2 side effects to be aware of. One is neutropenia, which happens in about a quarter of patients. The other one is edema, where patients could have swelling of their feet. They may even have some fluid accumulation in the lungs. Only about 3% had significant edema, but it is something to at least be mindful of. You want to stop therapy. Again, 20% had any form of edema. Only 3% had significant edema where they needed to be diuresed or were symptomatic from it. Okay, the therapy that's not yet, so all of those are FDA-approved products. They're just approved in that second line or later space. The bispecific antibodies are currently only available on clinical trial. We're anticipating that mosunetuzumab will be FDA approved at the end of this year, first for follicular lymphoma, and then we're anticipating epcoritamab and glofitamab will be approved in the spring of 2023 for large cell lymphoma. And so what are these? So again, you have an antibody that engages the protein on the surface of the tumor cell and an antibody that engages the T cells. Glofit actually has 2 binding sites for the tumor and 1 for the T cell. And then you have this kind of strange looking structure over here, which is IgM, which is, instead of it being an IgG antibody, it's an IgM antibody. So you have 10 options for binding the tumor site. So let me walk you through glofitamab, which I think will be FDA approved next spring. This was a single-arm phase 2 study, studied in, again, transformed patients, but also large cell lymphoma NOS, high-grade B-cell lymphoma, primary mediastinal. When we look at the breakdown, you can see, again, almost 20% of patients with transformed disease were included in this study. Again, heavily pretreated. Despite that, the response rates were very favorable. Over half had a response. 39% had a complete response, and it was also durable. So again, looks quite favorable with a single agent in that 3rd line or later space, which is why we think it will be approved in 3rd line large cell lymphoma. When we look at the larger expansion, again, suggesting that there is this tail to the curve. So we do think that maybe about 30% of patients could potentially have very meaningful and even potential cure with glofitamab. Epcoritamab is another CD20, CD3 bispecific. What's unique about it is a subcutaneous injection. So that means a much shorter time in the infusion center, which is important because this is dosed until progression or intolerance. So again, you can see here the breakdown of who these patients were. You do have some grade 3B folliculars, which are commonly excluded, but you also have your general large cell and high-grade B-cell lymphoma patients. Again, a large number of patients had a response. So this 0 is baseline. So you can see all these vertical lines that drop below 0 means a reduction in tumor volume. And it was independent of things like age, whether or not they were transformed or de novo large cell lymphoma. And if anything, maybe the transformed cases did even better, whether or not they'd had prior CAR-T or CAR-T naive. So we do anticipate this will be another approved option. And again, the goal for all of these should be a complete response. So they'll be approved first as single agents, and then they're going to quickly move into earlier lines of therapy in combination to try and enrich for those complete responses. So I'm going to shift gears a little bit for the last few minutes and talk about Richter's transformation. So this is a transformation that occurs in patients who have CLL or chronic lymphocytic leukemia. Fortunately, it's less common than what we see with the transformed lymphomas from follicular or marginal zone lymphomas. So about maybe 20 to 30% of patients with follicular lymphoma will transform. It's probably closer to 8 to 10% of patients with CLL will transform. But unfortunately, the outcomes are far less favorable than what we see with transformed follicular marginal zone lymphoma. And it's not entirely clear to us why that is. Some thoughts are that, CLL generally happens to patients with a median onset of age 70, 72. And so if you have a transformation, you're 75 to 80, and you may not be able to tolerate intensive therapy. So maybe the therapy may not be aggressive, just given the patients that are experiencing this. But more likely, it's probably the fact that the T cells in CLL are less effective. And so some of these immune therapies may not be as effective. One option is to target BCL2. So I mentioned BCL2 with follicular lymphoma. So venetoclax is a therapy that's actually approved for CLL, and it works quite well. And just this bar here, very small numbers, but suggests there might be activity in patients with Richter's transformation. So there was a study building off the EPOCH backbone where they just essentially added venetoclax to EPOCH. And you can see there is a ramp up of venetoclax because it kills cells so quickly. In the first couple of weeks, patients are actually at risk for tumor lysis syndrome. And so you have to give it slowly over the first 4 weeks. But for these, again, relatively small number of patients receive venetoclax, rituximab, and EPOCH. And again, Richter syndrome is just one of the highest risk groups we have. You can see among the CLL prognostic factors, 40% had a P53 mutation, which generally confers a very a poor prognosis. Over half had bulky lymph nodes, and you can see the prior therapy listed for patients for their CLL that preceded the transformation, including a small number who'd had venetoclax previously. So these curves to me look much better than those curves I showed you at the kickoff of this section, suggesting that these do look to be more favorable than what we might expect with standard treatments up until the introduction of venetoclax. We'd need a randomized study to say that with certainty, but this at least looks promising for, again, a very poor risk situation. What do we do if patients have already failed frontline and now are in that relapse refractory setting? Well, there's a new BTK inhibitor, LOXO-305 or pirtobrutinib, that's likely to be FDA approved soon. And you can see here, there was, again, small numbers, but very impressive responses with this single agent. It's an oral therapy for patients with Richter's transformation. So that's encouraging. So I think that will be a potential option for patients. And the other thing that's unique, as I mentioned, the T cells are less active in CLL. And one reason might be that there's more PD-1 expression on these cells, and PD-1 is a checkpoint. So it's a way that tumor cells can turn off T cells or kind of quiet them down when they're trying to get rid of cancer cells. And we have PD-1 inhibitors that have really changed how we approach a lot of the solid tumors like melanoma and many others. And so this just demonstrates, though PD-1 expression is infrequent in other B-cell lymphomas, it seems to be more commonly occurring in Richter. So there was a study at MD Anderson led by Nithin Jain looking at the combination of nivolumab, which is a PD-1 antibody, in combination with ibrutinib, with the idea that ibrutinib could skew that phenotype of T cells to be more favorable, and then apply the checkpoint inhibitor. And again, you can see all these patients had Richter's transformation. You can see the breakdown of their prior CLL status and treatments. And of the small numbers here, but 42% of patients had a response, including 8 that had a complete response. And some of these patients went on to get things like transplant therapy. So this is really encouraging, though, again, small numbers. The same story plays out in CLL as we see in follicular lymphoma. You can have both clonal evolution, but you can also have these de novo large cell lymphomas that arise independent of the prior CLL. So sort of that divergent evolution that occurs. These clonally unrelated, so this de novo large cell lymphoma, those patients do much better than those that are a linear progression of the disease. So it is actually important to see if we can make that distinction, because for those patients that have clonally unrelated, I would approach this just like your de novo large cell lymphoma, with either R-CHOP or POLA-R-CHP, depending on IPI and other factors. For those that are clonally related, maybe I would consider something like a checkpoint inhibitor plus a BTK inhibitor, or some of the more novel BTK inhibitors, because these outcomes are much less favorable with standard treatments. So I'll end by giving you an update on my 2 cases that I kicked off this session with. Again, my first patient who'd gone 5 years with follicular lymphoma, he's starting R-CHOP next week because he didn't have any of those IPI risk factors that would have qualified him for the POLARIX study. And then our clinical case number 2, actually that patient underwent Axicell standard of care CAR-T in November of 2020. And I'm happy to report she's still in a complete remission now, nearly 2 years out, doing quite well. So I hope I was able to illustrate that though we do worry about transformed disease, there are a number of new treatment options that are emerging almost every year or every month. And so it's important first to recognize it, and some of the clinical tools that may be helpful is the presence of B symptoms, LDH being more than 2 times the upper limit of normal, calcium being elevated, and then high SUVs on PET. A biopsy is generally still recommended because if we can show that it's large cell lymphoma, it opens the door to all the large cell lymphoma treatments that have emerged. We still have to individualize therapy because we have to take into account what the treatment was for their pre-existing indolent disease. Again, if patients had R-CHOP for follicular lymphoma, for instance, we're not going to give R-CHOP again with the diagnosis of large cell lymphoma. We're going to move straight on to those newer therapies in that later line of treatment. Again, most of what I showed you is therapies that we use for large cell lymphoma because that's generally how we approach this disease, though with one exception, which is Richter's transformation. So this is a unique subgroup with much more unfavorable outcomes and a much greater need for clinical trials to really help us understand. So for those clonally unrelated large cell lymphomas that arise in patients with CLL, I would approach it just like your de novo large cell. For those that are clonally related, I might try a more targeted approach. And I do think that cellular therapy probably offers a tremendous amount of hope for patients where the outcomes previously had been quite poor. So with that, I will stop talking and happy to take any questions for the next 10 minutes or so.